I'm just trying to. My wife just mentioned she got gas in our lottery tickets. Yeah, we have to drop off the doctor's whatever she wants to. With that, like, I want to. Not till 2030. This is the climate change study that's so
yeah, I don't know.
stuff in the toy hospital, and it's like a toy hospital.
Yeah.
That's what we're going to do in this place.
Yeah, I get it. You should have been Yes.
Yeah.
I don't think so. I get the sense that they've never. Something should be happening. I had a conversation
Well, welcome to 2018. Happy New Year to everyone, and to this special edition of the Health Policy Commission. So I want to thank all of you for coming. We have some important business to attend to, which is really a continuation of the meeting we just had back in 2017. So we do have a quorum, and I know a number of our members who have been very faithful, have come to almost all the meetings, couldn't make it because this was, as I said, not normally on, it was not on the agenda when David and the team put it together for the year, but we needed to have this meeting to complete our responsibilities in a number of areas. So that's why they couldn't make it, so they are forgiven. So first, let's see, we have the minutes from our December 12th meeting. Are there any additions or corrections?
So moved.
Good.
We're just keeping you on, like,
I know, I gotta take a motion on the minutes second. Very good, thank you. All right, if there are no additions or corrections, all in favor? Any abstentions or negative? No, good. Okay, so I'm gonna turn this now over to David, our esteemed executive director, to talk about the opportunities that we are gonna engage in with respect to our new investments. David?
Great. Good morning, everyone, and Happy New Year. It's great to be back here again, just a short time after our last board meeting, and a lot of important agenda items today. For the main meeting today, we have 2 agenda items. So we have a proposal around a next round of investments by the Health Policy Commission, seeking your consideration on that. After that, we will move towards consideration of the final cost of market impact review for the proposed transaction between Partners Healthcare and Mass Eye and Ear Foundation. So we'll walk through the final report and engage in a discussion with commissioners on that report. Following those 2 agenda items, we are planning to move into an executive session. So at that point, it will be a closed meeting to the public, and at that point, we'll be discussing the performance improvement plans and the confidential entities that are may be eligible for a performance improvement plan. I would say to the audience at the outset, we do not expect to come back into an open public session following that executive session. So while you're welcome to hang out, there's not going to be another part of the meeting. And we will report back at the next full public meeting on at the end of January as to the results of that executive session. I would also want to note we do have one commissioner who's not here in person but is live streaming. Wendy Everett is participating on the web and is going to be text messaging questions that you may have throughout the party. So the first agenda item here today is actually revisiting an agenda item that we spent some time on the last board meeting, which is the next round of care delivery investments. And so we'll move through this relatively quickly. We did spend some time on this at the last meeting, but had a number of questions and considerations that commissioners had that we felt best prudent to table the discussion at the last board meeting, continue to work on it a little bit more, and we'll walk through some of the changes we've made as a result of some of those really good conversations. So on slide 8 here, the main design of what we're proposing has not changed. We're talking, considering a $10 million opportunity, really focused on innovative ways to reduce avoidable acute care use. So think readmissions, think ED revisits, and also really having an emphasis on moving the care delivery system forward in this journey towards transformation. And so we think with this $10 million investment, we can continue to be and support the leading edge of some of these models that can do 2 great things, have great patient outcomes and also reduce costs and unnecessary utilization. So you can see here on this page is just a summary of this $10 million opportunity, up to $750,000 per award, some of the outcomes we're looking for. And we're looking at basically an 18-month cycle of performance for this grant opportunity. To provide a little bit more focus to our applicants, we've designed 2 funding tracks. One is related to models that would address health-related social needs, and the second is around addressing the behavioral health needs. And here we know there is great emerging evidence that care delivery models that can address both these things for complex, vulnerable patients can be very successful in, again, having great patient outcomes and reducing unnecessary utilization. I would note in the orange at the very bottom of this slide is kind of a sub-track, which is around engaging patients in opioid use disorder treatment who arrive in the emergency department. This is a mandate that the legislature gave us in a previous budget, and so we are including that as a sub-track that people can apply for and receive funding for. There's an evidence-based model here that was tested at Yale New Haven and had very good results in terms of engaging patients in treatment reducing repeat overdoses, reducing mortality as a result of really connecting people right away as soon as possible into treatment for opioid use disorder. So we know that there are many institutions in the Commonwealth who are very interested in testing and piloting and being a leader on this particular model as well. So those main design things haven't changed. What we have changed, and you can see here on slide 10, is we did make some modifications and enhancements to our design to really strengthen and strengthen our proposal around ensuring non-duplication with other funding sources, and specifically wanting to make sure that there was non-duplication with the Mass Health ACO program and the incredible financial commitment that the federal government is putting into that program through the DSRIP funding. And so we had a number of really positive and constructive conversations with the Mass Health staff, the DSRIP staff, the Secretary's staff, in terms of how could we ensure that we're aligned with, of course we want that alignment, but ensure the non-duplication of where our funds are going to be used. And so we've put together a couple of different strengthening our proposal in a couple of different areas, and I'll walk through this quickly. One really is around the non-duplication of the funds disbursement. And so one of the first things that we thought would be really helpful is just having closer collaboration with our Mass Health compatriots. We work with them very closely, but in this process we think their insights would be really valuable to participate as part of the review and selection committee, so that they're with us reviewing all of the applications and can give their inside knowledge and insights into how these different organizations are working in the Mass Health program and help guide us as we think about what are the most competitive proposals. Additionally, we do expect that we'll have continued and ongoing engagement with Mass Health staff, even in the course of the grant cycle, whenever we come up with issues and can share information back and forth. Secondly, we strengthened in our application that HPC applicants to this program must provide a clear description of what they're doing with the DSRIP dollars, and include a statement around what are their internal controls for ensuring non-duplication. And that would be something that we would evaluate and score more competitively if they had very strong internal controls. Thirdly, we are restricting some patient populations that are scheduled to receive enhanced funding through the Mass Health DSRIP funding, and basically saying for applicants to ensure that we're not commingling funds for these specific patient populations who are going to be receiving enhanced services through the Mass Health DSRIP program, that's not what the HPC funding is for. And the HPC funding in some circumstances may be used to wrap around that DSRIP funding to provide enhanced services to other patient populations, such as the commercial population or to the Medicare population, or to other Medicaid populations that may not be receiving those enhanced services specifically through the Mass Health ACO and DSRIP programs. And then finally, we always have in our contract as a matter of law that they cannot duplicate the funding here, and we require attestations at the stage of every reimbursement of dollars that we're giving them. The second category that we talked about was program evaluation. And here we had always envisioned that the HPC applicants would be designing their own proposal for how they would evaluate the effectiveness of the care models that they're proposing. What we did now was really beef that up a lot more and make sure that when they're describing their evaluation to us, that they really must take into account how are they going to ensure how are they taking into account the fact that there are going to be other funding sources coming in, that there are going to be complementary care programs going at the same time, and asking them to really come forward at the outset with a clear evaluation plan that will be able to mitigate the threat of kind of duplication in some of these efforts. Also here, not written on the slide, for ACO applicants, they would be required to describe to us also how they're engaging in the Mass Health evaluation program and how that would be complementary and again non-duplicative of what they would be proposing to evaluate for these particular care models. Finally, recognizing that many of the applicants who are interested in these funding are Mass Health ACOs or participants in Mass Health ACOs, which goes live on March 1st. We really thought it was a great idea to extend the timeline to provide additional time for these applicants to put together their applications and to be able to file them at a time that is not at the exact same time as the launch of the Mass Health ACO, which was the previous recommendation. And so we're now recommending that we push that timeline out by 5 weeks, giving both the applicant more time to prepare good competitive applications, but also avoiding this log jam at the beginning of March in terms of everyone's time, energy, and resources.
David, this is all great. Remind me, and maybe the other commissioners as well, how this fits into previous investments. I mean, is this a totally separate effort, or does it build on some of the other investments some of these hospitals may have made?
We'd like to think it definitely builds off of the experience that we had in the CHART program, as well as in our healthcare innovation investment program, but is really, I think, seeking to take that to the next level. And again, I think we'll be seeking very strong competitive applications that are really focused on these specific modes of being able to take care of delivery. We heard a lot at the last board meeting about the CHART programs and how they have been working to engage with behavioral health patients, address health-related social needs. So I think it does provide a little bit more focus on those specific areas. And part of what we hope to accomplish is to continue to contribute to the evidence base that addressing behavioral health needs, addressing health-related social needs is worthwhile and a good investment. And we think that that's a place where we can continue to add to the dialogue and the evidence through these investments.
David, can you review for me who the applicant pool would be for both tracks, and particularly because of the emphasis on behavioral health, where you see the community behavioral health agencies in that?
So this was another source of some conversation at the last board meeting. I think what we're proposing is consistent with what we had last time, which is that all providers are eligible to apply. However, we are giving a competitive advantage to Mass Health or HPC certified ACOs, their participants, and to CHART hospitals. And the thinking there really is that we are trying to move this entire system forward into that ACO model. And so the more that we can align the incentives around investment programs to be able to do that, I think even adds more momentum towards that new model. But we also didn't want to foreclose the ability of other community-based mental health providers, other institutions who may not be part of a Mass Health ACO, to be able to put together a strong application and be competitive. So while we do give a competitive preference to those institutions, it is not foreclosing anyone from being able to apply. Part of our strong competitive factors here are around sustainability, and we do think that the ACO model may provide the best case for sustainability moving forward, where we know that there'll be a risk-based contract.
Yeah, not completely thought through here, but just around the certain patient populations piece that receive services through the national ACOs may not be included in the target populations for HPC funds. I'm assuming there's a lot of hospitals there'll be a group that are district hospitals that are applying for these funds, and then there'll be non-district hospitals that are applying for the funds. So I guess for the district hospitals, it seems like there's probably gonna be a big overlap between the district money they're using for that population and the money they're using from the HPC pool for that population. So what's left for district hospitals to use this money for? Are they gonna divide, like, how does it interact with their district dollars? Do they say, well, we're gonna use this for that? Just wondering kind of how that interacts and what's left for the district hospitals that receive this money to do with it and how it impacts their use of district dollars.
So for the non-district hospitals, this restriction does not apply. And they would be able to apply it towards their Medicaid population. So to give a very concrete example, for track one, which is around addressing health-related social needs, the district program does include the availability of what's called flexible spending. And these are exactly what this track is about, providing flexible spending for patients who to meet some of their health-related social needs. And I think one of the categories, is housing, for example. And so what we're proposing is that, however, under the DSRIP program, those flexible services are only eligible for a sub-part of the patient population. They're eligible for patients with serious mental illness and patients with needing long-term supports and services. So those patients would not be able to be included in the target population. But basically all other Mass Health DSRIP or Mass Health ACO patients would be eligible to be included as part of the target population. And so one could imagine an applicant coming forward and saying, we want to do this great housing stabilization model. We're going to get DSRIP money to do it for this patient population, and now we're going to wrap in this HPC funding to expand it to an even greater population. And that could be a way that they can wrap around it. So it's really trying to avoid the commingling for those certain populations. But I think the hope and the goal is that there are still many other patient populations that they can use our funds to wrap around the DSRIP funds and to have potentially a more comprehensive care model.
And when the chart funding runs out for that institution, they can use their DSRIP dollars to do what the chart funding was doing before?
No. So, again, part of the goal here is to create the evidence base and create the, what we would hope is that these institutions, having worked through this 18 months in, can see the benefits that they're accruing by making these types of investments, and that they're saving money on their global budget under the Mass Health ACO, and would want to continue these, continue funding these programs, even outside of the direct DSRIP allocation.
I mean, that's really the opportunity, is can you, by investing in some social determinants to a more generalized population, do you see savings that you can then reinvest?
Excellent.
And perhaps I'm the most optimistic I can be here, but if there are good results that come from this, maybe there is an opportunity to go to the federal government and to say, we can see that this works, and you should be allowing even more flexibility in how the flexible services can be applied.
Oh, it's early in the
You're in your fake news days.
Okay, any other questions, comments?
I just want to say, since I appreciated the pause in the last meeting of the opportunity for the HPC staff with my folks and the Mass Health team to sort of just make some adjustments around the clarity. So very much appreciate that. I think that's strengthened both working relationship, but even more important, sort of the opportunity for collaboration and maximizing the benefit. So I appreciate that.
I know, this is really good.
Yep.
So this is really great. Are we going to take a pretty broad view of what we mean by health-related social need? I mean, it's a chance for real innovation here.
So we are not being prescriptive in the request for proposals. However, we do have strong competitive factors around, what is there an existing evidence base for some of these health-related social needs? What are the expectation in terms of being able to achieve savings in the timeline that we're thinking about? But we are not being prescriptive, and we really want to allow the applicants to be innovative.
Just to pick up on that comment, I think it's going to be a great opportunity because, in fact, in the waiver, we had to really negotiate from what we submitted, which was a broad, flexible social determinants pool, to a much narrower definition in our final negotiations on the STC with CMS. So the good news is, we're one of the few waivers that actually has flexible support dollars in it, but it ended up in the final negotiations being narrower than what our original intent was. So I think we have some opportunity with these dollars to perhaps innovate on some things that we had aspired to in the waiver that we just to the final negotiations and we're not successful, so I'm hopeful.
Any other questions? Again, thank you. So now we're prepared to vote on the motion, which is listed on page 11. So
Second.
all those in favor of the motion to move forward on this investment?
Aye.
Aye. Any opposition? Abstention? All right, sounds good. And by the way, I do want to comment positively. I think this positive pressure on evaluation and creating the kind of information to understand how these work is going to be very important, not only for us and for this state, but I'm hopeful that this kind of information can see the light of day around the country to sort of improve these kinds of efforts in all places. So thank you for, I think, putting that in a strong way. Okay. So we're now going to move to the next section, which is the comments and final approval of our report vis-a-vis the Mass Ioneer and partners.
Great, and I'm going to turn it over to the team to walk through the presentation here. But we're going to start with our standard update of notices of material change. I don't know what we had dubbed this part of the agenda before, but we'll move through this quickly and then get to the meat of the agenda. So, Megan Wolf.
Thank you, David. Since 2013, the HPC has received notice of 88 provider transactions, with clinical affiliations the most frequent, followed closely by physician and hospital affiliations. We currently have 3 notices under review, as you can see on this slide, all of which were received prior to the last board meeting. We also elected not to proceed to a CMIR for 3 transactions. These were the proposed acquisition of Reliant Medical Group by Optum Care, a subsidiary of United Health Group, a proposed clinical affiliation between Harrington Memorial and UMass Memorial, under which several Harrington OBGYN physicians would apply for staff privileges at UMass, and the proposed acquisition of AdCare Hospital of Worcester, a for-profit provider of inpatient and outpatient substance use disorder treatment services with locations in Massachusetts and Rhode Island, by the AAC Healthcare Network, a national for-profit provider of substance use disorder treatment services. For each of these transactions, our reviews suggested limited scope for increases in healthcare spending, and we did not review evidence suggesting negative impacts on quality or access. We initiated one cost and market impact review last month, the proposed merger of Care Group, Leahy Health System, and Seacoast Regional Health Systems, the related acquisition of the Beth Israel Deaconess Care Organization by the merged entity, and the contracting affiliation between the merged entity and Mount Auburn Cambridge Independent Practice Association. I'll turn it over to Kate to talk about the final report on Partners' proposed acquisition of the Massachusetts Ioneer Infirmary.
Great, thank you, Megan. So as a reminder for our commissioners, we issued a preliminary report on Partners' proposed acquisition of Massachusetts Ioneer Infirmary and its affiliated physician group, Massachusetts Ioneer Associates, on November 1st. Finding, among other things, that there was potential for commercial spending to increase $20.8 million to $61 million annually as a result of anticipated increases to hospital and physician rates. We also highlighted the particular implications for tiered and limited network products, as well as potential access implications for members of MassHealth MCO products. On November 30th, the parties provided a relatively brief response to the preliminary report, but included some new information about hospital rate increase projections and Massachusetts Ioneer's financial condition, which had not been previously provided to the HPC. Staff has closely analyzed all the material provided, including this new information, in concert with the commissioners and with outside contracted experts. And today we wanted to summarize their response, our analysis of that response, and the changes in the final report. Pending a vote to release the final report today, the report will be referred to the Attorney General's office as it meets the statutory standards for a mandatory referral, and it will be provided to the Department of Public Health Determination of Need program, which is also evaluating the transaction concurrently. With regard to rate increases, in the parties' response to the preliminary report, they concede that there will be some rate increases, but they state that they will be somewhat lower than what the HPC modeled. Specifically, the parties didn't dispute that physician spending would increase by about $5.9 million annually as the Massachusetts INR physicians join all of the partners' physician contracts. But they provided a new estimate of hospital spending increases, stating that they would be about 33% lower than the HPC modeled range, or about $10 million. So in other words, the parties concede that there will be about $16 million in increased spending annually for commercial payers. However, the parties provided no backup with this new figure of 10 million for hospital rate increases, so we were unable to assess anything about that estimate. But most importantly, they did not provide any measurable commitment that they would limit spending increases to that figure or any other figure, so they could very well seek increases in excess of that. The parties also, do we have a question?
Stop you there.
Yeah.
So, they indicated, that for the first time, that there would be increased spending, and increased prices as a result. But so on one level, you said they didn't give any indication of how much that would be. And then on the other, though, they said that our estimates on the low end were too high.
So just to be clear, they had stated that they would seek market competitive rate increases for Mass INR as part of the transaction in their notice to us originally. So it was always understood that there would be some rate increases that would be sought as part of the transaction. Prior to their response to the preliminary report, they did not provide us any estimate, despite a request to provide such an estimate. They did not provide us an estimate in the lead up to the preliminary report for how much that impact would be.
So what is this, the first bullet? I don't, it says that the parties did provide for the first time an estimate of spending increases that would be, so.
This was the first time they provided us a figure. They provided just a statement in the notice to us originally that they would seek market competitive rate increases, but despite a request for a figure, they did not provide one until November 30th.
No, what I'm trying to understand is if this were to go forward and we and or the state would continue to monitor the performance and the spending was significantly higher than that first bullet, would that technically be in violation of what was agreed to?
So there is no agreement. So the key point here is that they provide an estimate of what they think the rate increases would be, but no commitment to those rate increases. So their projections, they could elect to exceed those projections. They haven't committed to us or to anyone else that they would stick to that.
Have we asked them for a commitment, for example, to the benchmark or to those particular numbers?
The preliminary report did include language that invited the parties to make a commitment, and they did not do so in their response.
Did they ignore it, or did they say they would not make a commitment?
They did not. They did not state that they were making a commitment. They did not specifically say we are not committing.
So that's still open.
Absolutely, they still could make a commitment, that's absolutely true, and as this is under review by other agencies, there is a forum for them to make that commitment.
You know, assuming that all the reporting in local papers is accurate, and you look at Mass Eye and Ear, they were struggling. So just looking at some sort of increase may be necessary in order to maintain quality, which is something we need to look at as well, right? The question becomes how much of an increase is reasonable and expected given their history and stuff. I think that's the way we gotta look at it. I don't personally see an increase necessarily as negative. The question is to what extent.
Great, that's actually a great segue to the next point, which is that they did provide us more information in their response about the financial condition of Mass Eye and Ear. And so, you know, they provided a Standard & Poor's bond rating report in their response to the preliminary report, which we analyzed closely alongside other financial information. So we analyzed that in the full context of their audited financial statements, other third-party assessments like Moody's, Mass Eye and Ear's own statements and projections, both in the S&P report and ones that were provided confidentially to us, and a number of other sources. Based on all of that information, we have updated the final report language around their financial condition to note that while Mass Eye and Ear's financial position has weakened in recent years, there's no indication that it is in imminent danger of closure. And it's continued to invest in its clinical operations. And some recent information suggests that its financial performance may actually be starting to improve. And in fact, they also provided some information showing that they were undertaking efforts to improve their financial performance completely to the side of any transaction with partners. We also highlight in the final report and in our response to the parties' response that while the parties claim that the transaction is necessary for Mass Eye and Ear's financial health, they concede that significant rate increases are not necessary. And so, as you may recall with the discussion in the preliminary report, the parties projected very substantial operational savings as part of the transaction, reducing their annual operating expense growth from 5% to 4%. With the potential for additional, somewhat substantial efficiencies over time. If those projections are realized in a few years' time, we're talking about more than $20 million annually and growing every year thereafter. Achieving savings of that scale on their own would go a long way to improving Mass Eye and Ear's financial performance. And then the final report does provide a little more detail about exactly where they expect to achieve those operational savings.
So I want to thank you for bringing that up, because I think it's important to emphasize that we hear all the time on any transaction that comes before us, the potential for efficiencies, savings, and the like. But the question always is, well, all right, if that's going to happen, how does it help the people that pay the bill? So in some cases, does it lead to price reductions? And in this case, Ron, as you pointed out, it may be that they do need to see improvements in their financial position, but it doesn't necessarily mean they need a price increase if this transaction would have reduced expenses and or make other efficiencies. So I think it's very important that your second comment is very important, that yes, we recognize the potential for the fact that this organization needs some improvement in their financial position. It doesn't necessarily imply that they have to have price increases to make that happen.
You know what's interesting, Stuart? The little experience I have in these acquisitions and around the country that I've looked at, although they all claim to achieve these operational efficiencies, in actuality, you see very little success in that arena. As a matter of fact, you actually see an increase in operational expenses. Now, from your experience with organizations that we've approved in the past, have we seen operational efficiencies? Have they been able to achieve them, or is that something that we have not been able to measure?
That has not been a primary focus of our kind of post-transaction reviews, and I think this is an important question around this particular transaction is where there are operational efficiencies that are projected, will those be realized on what timetable? And they do, and I'll refer to the team, they do, and we do provide in the final report a little bit more detail about what they told us around how they expect to achieve those financial efficiencies, some of which are consolidating backroom staff and some other administrative savings. Some we think are probably more likely to occur because they involve, capital financing, and they would be leveraging partners to do some of that work, and that may result in some immediate kind of financial savings. But I'll refer to the team to talk a little bit more about how they project to do that.
Sure. So some of the key points that they make is that Mass Eye expects a substantial increase in demand for its services with an aging population over time. So they expect that the transaction will allow them to avoid some capital expenditures, that they'll be able to use partners' existing sites, some underutilized ORs in particular, and not have to build those on their own. They have highlighted an ability to purchase goods and services and access capital at a lower cost through partners. They expect to engage in joint long-term real estate planning. In particular, Mass Eye has locations both right next to Mass General and in Longwood, and there's really an opportunity to kind of work together to use those resources jointly and figure out how to most efficiently do that. They've highlighted that Partners has a vast research infrastructure, and Mass Eye can really participate in that and reduce some of the costs that they've had to sustain having that research infrastructure on their own. And similarly, Partners has a vast teaching infrastructure that they believe that they'll be able to extend to Mass Eye. And then there's a range of administrative services and corporate services. So revenue cycle, treasury, employee benefit, payer contracting, asset management, information services, all of this that they expect to be able to extend to Mass Eye, and also because those are kind of partners-wide services, to the extent that there's one more entity kind of sharing in the cost of those, it might also reduce the cost for other partners entities as well. And then they've also highlighted that there are opportunities for future efficiencies, in particular because the Mass General and Mass Eye campuses are so close. They could explore things like, having shared kind of parking management, or shared nursing staff, or shared laboratory services. All of that is kind of remains to be seen, but there are lots of opportunities for efficiencies there as well.
David? Oh, no, why don't you go through, then I'm going to make a comment.
Sure. So that was all I had to say actually on financial conditions. So if there were other topics on that.
Yeah, just a quick follow-up. Do they have a goal in mind of how much money they need to do through savings or through this transaction to keep the hospital afloat? If there's an agreement that they're struggling, they were doing things to try to improve, do they have a goal, a number in mind that they need to do revenues or efficiencies to stay afloat?
They have not stated a goal. We can certainly assess their financial information, including confidential information provided to us, sufficient to ascertain that if they were able to achieve operational efficiencies of the scale that they're talking about, it would likely go a very long way into stabilizing their finances.
Right. I'm sure they have an internal goal, what they need to stay afloat, and either through this transaction hasn't helped them meet that goal. And then just how did I read the letter? I'm just still trying to figure out the 10 million number, the 33%. I know how we got to how the HPC staff got to the numbers in terms of their negotiating the MGA rates or the community hospital rates. What do they compare themselves to in terms of getting to this 10 million number?
They provide no backup for it whatsoever. So, we're kind of at a loss of how to even analyze that when there's no rationale behind it, no backup data. And so we really can't run down the reliability of that estimate. And, looking at Partners' past practices with acute care hospitals, it is a reasonable expectation that they would seek to achieve price increases the same way that they have for other hospitals that they've run into their network.
So in the response, did it say what that number was based upon?
So is the response from Mass Ioneer or was the response from partners?
It was a joint response, they issued it together. Great, so with regard to access, the party's response does include a commitment that Mass Ioneer will continue to participate in its existing Medicaid MCO products, which was responsive to concerns that we raised in the preliminary report. It is our hope and expectation that this would also extend to new Medicaid MCO products, and we've noted that in the final report. The parties do not provide commitments regarding participation in commercial, tiered, and limited network products, and as described in the final report, this could have a couple different implications. So if Mass Ioneer's prices are not competitive enough to be included in limited networks or to remain in lower cost tiers, this could have access implications for members of those insurance products. On the other hand, if payers determine that Mass Ioneer is such an important specialty provider that they have to include it in those products at even a much higher price, it could have implications for the savings those insurance products are then able to achieve.
So, in your bullet, you say the parties suggest that the proposed transaction will not impede access to MEEs for patients in commercial tiered and limited networks. But if they raise prices, so they're not gonna pull out, but they may increase the rates and therefore put them in a situation where the networks can't afford them anymore.
Correct. They highlight a couple different things. Again, there isn't a commitment there, so they highlight that it would be in Mass Ioneer's financial interest to stay in payer networks. I think by that argument, all partners hospitals would be in limited and tiered networks, so I'm not sure that's necessarily the strongest of arguments. And then they also highlight that some of their specialty non-acute hospitals participate more broadly than their acute care hospitals and point to that.
Remind me, since we had this discussion many moons ago, Partners has developed what is the Partners policy vis-a-vis networks where a network will include certain components of Partners but not others? Does Partners demand that all their facilities have to be in when none can be in? How is Partners operated in this world when it comes to tiered and limited?
I'm not sure that it's a policy per se, but we do highlight in our final report that the Partners acute care hospitals by and large aren't in limited network products. Some of their non-acute hospitals, Spalding and McLean, are, and the tiering varies by insurance network. By and large, the AMCs are in higher priced tiers for pretty much all of the tiered network products, but payers treat their community hospitals differently.
But it is fair to say that Partners would allow some of its facilities to be in a network and not require all of them to be in. So it's possible that the ME, Mass Ioneer, could be in the networks while other facilities are not. And they would not exclude it. That's what they're saying.
Sure, so obviously it's a negotiation, right? So it's a negotiation, so it depends on what the payers will agree to in terms of a price level. So I do want to emphasize that this isn't just a decision.
It's just important
they would
because
make.
in other parts of the country, I've heard where a system basically says it's either all of our facilities in or none can be in. So it's good to hear that Partners will allow some of its facilities in, and that's why this statement's here, so thank you.
Although I would note, and I'm just looking at a graph which is on page 34 in the report here, that for the top 3 commercial payers, the major acute care hospitals in Partners are not included in the limited network products of any of the top 3 commercial plans, Blue Cross Blue Shield, Tufts, or Harvard Pilgrim.
No, including the community hospitals.
Including Faulkner, North Shore, but as Kate mentioned, their specialty hospital like McLean may be in some of those limited network products, but their main acute care hospitals are not included in the top 3 commercial limited network products. They are included in the tiered network products, and there you do see a difference because the Mass General may be in the most least efficient tier, and Faulkner may be in a more favorable tier. But in the terms of the limited network products, they are not participating, and Mass Ioneer today is for Blue Cross Blue Shield and for Harvard Pilgrim.
No, yeah, I understand. So what I was trying to make a distinction, it's one thing for a plan to choose not to include a facility in their limited network because of the price of that facility or something about its quality or whatever it is. It's another thing for the provider to exclude it because other parts of it are not in it. And what I'm hearing is that Partners does not have that all or nothing strategy. So it would allow potentially Mass Ioneer to be in the networks while the rest of them are not. And that's what it says in that bullet.
Potentially, but again, it's worth noting that Mass Ioneer is an acute care hospital, and so they could very well treat it the way that they've treated their other acute care hospitals, and as David very helpfully pointed out, those
Well, that's
tend
why
not
I'm
to be in
concerned
any
about the
limited
pricing.
network products.
If they price their product similar to what, say, Mass General prices, it may force an existing plan to have to exclude them because if they put them in there, then it would shoot up the price of the product and therefore it begins to lose its value. So
Exactly.
Those, Mr. Chairman, if you look at page 34 and you see that if you look at the tiered networks, we're gonna have an obvious visual in a couple of years or a year or so if this transaction were to go through and all of a sudden Mass Ioneer goes from being most efficient to least efficient as a result of pricing. Yeah, but you'll have we're speculating.
Yep.
So part of this is what are the facts and what are our assumptions. We have a visual here that we will know at some point in terms of payers, commercial negotiations as to how, if this transaction were to go through, how this pans out. Because our own rate increases.
but at this point, we have no choice other than to speculate, and they're trying to bring as much information. As I said, my concern is that it isn't that they're gonna be excluded on the partner side, but it may force the plans to put them from the most efficient into the lower category because of the higher rates. But again, it is speculation. Okay.
So with regard to quality improvement, the party's response reiterates what they had said in the lead up to preliminary report, that the transaction would allow partners to share innovative quality measurement tools and improvement programs with Mass Ioneer, but they claimed that they cannot share the clinical data with each other necessary prior to the transaction. That would allow the HPC and other state agencies to assess the scope and likelihood of improvement on their set of proposed quality measures.
Have we looked at this claim about HIPAA forbidding that sharing with us information? That's a surprising assertion that they can't tell us about their quality intent because HIPAA prohibits it.
We did look into this a little bit. Obviously, this is a little bit of a rabbit hole, so we were trying to balance how much energy to put into it. It is something that we've flagged, and obviously is a key thing for some of the other agencies that will be evaluating it, where clinical quality is a core part of the review process currently underway with the Department of Public Health in particular. And we know that this is something that the Department of Public Health has also asked about.
We did not, I think, assess whether this is right or wrong, but we did include in the final report that statement from them. The parties state that this is, and did not judge that either way, but felt it was fair to include their statement in the report.
In looking at some of the unknowns that we have, whether it's administrative savings, cost increases, where we really don't know how they came up with their numbers, or when we look at quality, does it make sense to, I don't know if this is possible, to go back to both organizations and try to get some clarification before we finally release the report, or is that not possible?
So we did that. That's why That's it. Why don't you
Right.
explain the process?
But,
Right.
but you can't go back again.
That's right, we asked them.
Okay.
Right, but I mean, the process is that, you know, in the lead up to issuing a preliminary report, we send a comprehensive list of information requests. The parties are required to provide all responsive information to those. That's what we analyze in the lead up to the preliminary report. The parties then have the opportunity to respond to the preliminary report. Here, the parties provided us new information that would have been responsive to our original information requests. But I don't think we would expect that they would provide any further information if we were to ask again.
I would just add, you know, this is the end of the process, and this is our final review. And really, this review is meant to inform the public and to be an effort in transparency. And in some cases, there may be places where there are not clear answers. And in those places, reasonable individuals and policymakers and others will need to weigh some of the very considerations that you're bringing up today, Ron. And you know, at some point we need to complete our review and lay out the facts as we understand them, and that's the stage we're at right now.
Finally, there are a handful of methodological and technical points, both raised by the parties and that we identified on our own, that we've addressed in the final report, where we've added additional explanations and clarifications. But ultimately, the findings in the final report are quite similar to those in the preliminary report. As summarized here, we estimate that total healthcare spending will increase $20.8 to $61.2 million annually if Partners seeks parity between Mass Eye and Ear's rates and those of its other acute care hospitals, and if it adds the Mass Eye and Ear physicians to all of its commercial contracts. The parties declined to offer any commitments to limit those price increases to mitigate the effect on payers and consumers, and they simultaneously expect to achieve substantial internal savings. The parties have stated that the transaction will improve quality, but it's unclear that the proposed transaction is necessary or sufficient to achieve improvements. And the parties propose to collect baseline data and set quality improvement targets only after the transaction is completed, as discussed. And finally, the parties have not described specific plans for when or where Mass Eye and Ear might expand its services. And while they've made commitments to continue Mass Eye and Ear's participation in Medicaid MCO products, they've not made commitments around participation in commercial tiered limited network products. So I'll pause there.
So let me just take a quick summary of, first of all, I want to thank the team. I thought the report was extremely well written and responsive to the requirements that we issued. So as I understand it, and please correct me if I'm wrong, first of all, Mass Eye and Ear is a high quality provider. It is in its areas, it is, you know, among the best in our area, if not in the country. A. B, it is for a variety of reasons having some financial problems. The bond rating that it received is not a high rating from my understanding of bond ratings. But as you pointed out, it is not that it's in jeopardy of going bankrupt, but it is in a position where improvements were needed. So that's the second, and you point that out. Third is that there are some real easily and translatable savings that could be generated by this acquisition, which you've articulated and like, you know, in response to Ron's questions, and it's well written in the report. So that is a positive, this acquisition, if it led to these efficiencies, improve the financial performance of Mass Eye and Ear, it would be viewed as a good thing. And I suppose we would be very supportive of it. Our concerns, however, is that even after these efficiencies and improvements in their financial performance, by the very nature of the Mass Eye and Ear becoming a unit of partners, it would not propose, but actually, given the nature of the contracts that Partners has, invariably lead to a price increase and a revenue increase in spending. Exactly how much we don't know, because it depends on how Mass Eye and Ear, both on its outpatient and its inpatient, is valued relative to the partners. Is it viewed as a community facility, or is it viewed as an academic medical? Clearly, if it's an academic medical and gets rates similar to what, say, Mass General or the Brigham get, then your high estimates come into play. If it's at the low end, the low estimates. So that's where your cost. And our concerns are really in the cost side, both in terms of price increases directly as a result of that, and then concern that by these price increases, it could put in jeopardy the tiered and limited network programs that many of our payers have put into place so that individuals can buy insurance at lower premiums. Did I summarize the pieces?
That was a beautiful summary. Thank you, Mr. Chairman.
Actually, Mr. Chairman, I want to just pick up on the themes you raised and add to them a little and then ask a question. It seems to me that on the financial side of the transaction, there's no real disagreement. Everyone agrees, that is the parties, and our analysis agrees that prices will increase. The only question is how much. Everyone agrees that there are potential for savings in the back office. Nobody knows yet whether or not they will actually be realized, or to what extent they'll be realized, or how big that would be compared to whatever role needs to be built, or so on. But actually on the financial side, there's not an enormous amount of disagreement. I think to the extent that there's any disagreement, it's that Mass Eye and Ear considers its financial position a little more precarious than either we do or the experts who have been working with us do. And I think it's natural that any organization looking at its own budget is a little bit more worried than someone looking out over the budget of 100 institutions and saying, well, which of these are the most likely to be in trouble, because you sort of see folks that are higher on the list and you just say they're not quite high on the list yet, so they're thinking a little bit more longer term about how they're going to do things or not. And I think implicit in their statement is some sense that if they don't get more revenues, they believe that in the future quality of medical care will suffer. They don't say that explicitly here, they don't say that if this doesn't go forward, the quality is going to go downhill, but there's this sort of implicit sense there. And so what they're really saying to the Commonwealth is, you should allow us to raise prices because that will keep up / potentially improve the quality of medical care that we're able to provide. So a couple of points about that. One is, neither we nor they, as you noted, actually say what that quality impact is. So it's very difficult to sort of say what would it mean in terms of quality and so on. And second, I think it's probably not our job to decide at the end of the day, is the cost impact worth the quality, worth whatever quality would come of this. I think God is to lay out that set of trade-offs to the extent there is one. I think what's somewhat difficult about this is that there's, while actually all of the parties together have done a fairly good job of placing in some scale what the financial consequences are, we really don't have any basis from what's here to think about what the potential quality part in the future is. And so I guess my question is, how does it evolve from here? That is, who would then take the next step and say, okay, I really want to model out what are the quality impacts? Is that what the determination of need is going to involve, or is that the Attorney General's action is going to have to? Or?
Before you get to that, I have a slightly different view of this situation.
Okay.
But I'd appreciate whether you agree with this or not. At the end of the day, if this acquisition goes forward, there is no Mass Eye and Ear. It is now part of Partners. and therefore its financial performance is no longer a unique entity of Mass Ioneer. It is now a unit of partners. We don't worry about the financial, the Commonwealth of Newton Wellesley. Mass Iron Partners worries about it and moves money around as it sees fit. So if this acquisition goes forward, the financial performance and quality ceases to exist. Bonding will be in partners, not in Mass Ioneer, the financial issue. So that's the first thing. The second thing is, and I don't want to put myself in the place of partners, but let me put myself in the place of partners for a minute. To the extent that partners is looking out and saying, I may need to invest X amount of dollars over the years, I want to get my money back. And as a matter of fact, I wouldn't mind getting a rate of return on top of that money. Therefore, partners need these rate increases to justify. Now, we've had this situation before in the very first set of when we looked at South Shore, where in fact what we were dealing with was a situation, and Hallmark for that matter, I remember Hallmark very much, where in fact the Hallmark was expecting partners to invest a fair amount of money in Hallmark, and partners expected to get that money back, and the way they were going to get it back was, so what I want to modify your statement is, once this acquisition goes forward, it is not a question. I have faith. Partners is a wonderful organization in terms of it provides very high quality care and at or above most. So the idea that somehow the quality of Mass Ioneer would not be at the highest level, regardless of whether they get a price increase, to me is not the issue anymore. Once the acquisition goes forward, it's now an important unit of partners, and I can't conceive that they would let that part of their system deteriorate.
Oh, I think that's right, and I think the issue is laying out the counterfactual of non-merger.
Yeah,
And what does that?
Then it's a different situation, absolutely. Yeah. So you want the question answered, but
I suppose the question is, who would take the next step in terms of judging whether the cost increases resulting from the price increases are worth whatever quality gains would accrue over time if you laid it on everyone's experience?
Can I ask your question in another way as well? So, on page 20, it says the parties decline to offer an unequivocal and measurable commitment to limit increases. Are we that organization, or is that the DON process and EHG? Right, that's my understanding.
So
I'm wondering.
So on all these conversations, I think it's really important to remember what the role of the Health Policy Commission is, the role of the Attorney General's office is, the role of the Department of Public Health. This is not the last opportunity for the Commonwealth of Massachusetts on this transaction, but the Health Policy Commission has a particular role, which is what we're discussing. Once whatever happens in this conversation, when it goes, there's a concurrent review happening at the Department of Public Health, the DON process on the acquisition, and they have the opportunity in their deliberations, when they look at this report, to come up with conditions. So, go back to that. I actually have a couple specific questions, but I don't want to get into the middle of this philosophical debate.
So I think the answer is what the Secretary just said. Our responsibility was to present as much of the facts as we possibly could. We're not free, we're more than free to make some speculation about assumptions, but ultimately the final decision rests with other organizations, and that balancing act is where that will take place. But I think that's the answer to your question. But go ahead.
So I just have a couple of clarifying points, and maybe they're trivial at this point, but I really do believe in objective and clarity. So on the bottom of page, I think it's the attachment A, I just, we're having this conversation about quality, but you quote on the exhibit that nonetheless, the parties have stated that Mass INER, has been put in quotes, will soon find it difficult to maintain all aspects of its clinical research and teaching missions due to a variety of financial pressures, including rising labor and pharmaceutical costs and reductions in federal funding for research and medical education. So I guess I just want to clarify that the quality is extraordinarily important, but in our report, we also say that they are presenting their financial pressures more than just quality, but a whole number of other factors. I just think it's important to put that in the record. And I'm going back to your slide on page 21. So I've been sitting here flipping back and forth. On slide 21, where it says the final report also notes that even while the parties claim blah, 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 I won't read it, everybody can read it. They concede that significant rate increases are not necessary, achieving the parties' projected operating efficiency or substantially improved MDE's financial performance. Maybe because I'm doing this so quickly, I'm missing. Can you anchor me in this report to that statement where I find that? Because I look at the footnote, I don't see it back in the report.
To the significant rate increases are not necessary.
Right, achieving the parties' projected operating efficiency was substantially improved. So I went to, again, the attachment, and it references, see final report, separate note 4, 48, 49, discussing the parties' expectation. I'm just not quite angry. And, you know, we can do that offline, but that's a statement, I see it on this attachment. I'm not seeing it quite as anchored as that would suggest. And again, it may not be material for this conversation, but I would like it perhaps after this meeting with staff to walk through that. And I agree.
We can do that, that would be great. And I do want to highlight on your first point, Madam Secretary, and I think this speaks to your point, Professor Cutler, as well. They do make claims around quality improvements that will result from this transaction, but in terms of a counterfactual, they also are stating that without this transaction, that there will be degradations in the quality, their clinical mission and their research mission. So it's not just around whether this transaction will result in quality improvements, but they're stating without this transaction, they could see further degradations in some of their ability to invest in those areas.
So let's see, you'll get that clarified?
Yeah, I can do that all.
Okay, great. Any other questions or comments? If not, I think we're ready to vote on the motion, which is on page 25.
I think before we do that, I just want to quickly highlight slide 24, which is new to the final report. Notably, this report will be referred to the Attorney General pursuant to the law and our regulations under a mandatory referral. So the law states that in situations where an organization, the resulting organization, in this case partners, has a dominant market share, materially higher prices, and materially higher TME, that we are required to refer the report to the Attorney General's office. And all of those terms are defined technically in our regulation. The transaction does trigger these three components, and so it requires a mandatory referral to the Attorney General's office. Additionally, we are providing the report to the Department of Public Health, and the report is very straightforward on both those points.
Again, if no further questions or comments, I think that the discussion is very good and detailed. And this is an important transaction, and it should. So with that said, the motion is on page 25. Do I hear a motion to approve this motion? Second? Do I hear a second? Second. All right, all in favor?
Aye.
Opposed? Abstentions? You're abstaining? Yes. Okay. One abstention. Very good. We're going to move forward. Thank you very much.
Yeah, just my comment here. So the work of this commission is an exercise in prediction. You look at the past and try to say what will happen if actions are taken, whether it involves a full cost market impact review or a decision not to review. And I'm increasingly of the mind that we need to know much more about the accuracy of our predictions and the representations of the applicants. So here's an applicant who's making representations, but not willing to guarantee anything. We are making predictions, which we will then lose control of. I just have this feeling that we need, as a commission, to launch a retrospective, disciplined review of the question: how good are our predictions, and how honored are the representations of the applicants after a number of years? Otherwise, we will just continue to be shooting in the dark. This is shooting in the dark, other agencies have responsibilities now to execute. Do we have a responsibility to look back now in a really systematic way? The earlier question on quality impacts, for example, I have no idea. I don't know. So anyway, I guess my question is pretty clear. I'm sure we're not doing that at all, but I think it's core to our effectiveness in the future.
Let me try to partially answer that and see if this makes sense to you. There are, in those estimates are two very different set of facts. With respect to partners or any other major delivery unit, we're going to run into this when we get to that is really late. There are contractual relationships, say between partners and the insurance carriers, that have been developed over years. And we have demonstratable proof of what happens when an organization that previously was not part of partners becomes partners, whether it's a physician group or a hospital group. We've seen this over and over and over again. When a community hospital became part of partners, there was an immediate increase in prices consistent with the contractual relationship. When a physician group like South Shore Physicians became part of the Brigham, there was an immediate increase. This is not an estimate. This is based on a fair amount of previous issues. Much of our estimates are from those types of changes. Where you get into the murky area and where we did not, much to my chagrin, I think the numbers could be quite much higher. In the world where an organization gains market power by virtue of an acquisition or merger. The reason why this is unlikely to be an antitrust, I'm now becoming more of an expert than I used to, still not at the lawyer level. Why this probably will not be an antitrust is that this acquisition will not fundamentally change the markets. They're already so powerful. So it's not like you're going to be taking a half powerful and making it into a much more powerful unit. It's in that world where you begin to say, based on research that's going on all over the United States, you see when organizations gain more market power, they use that market power to raise prices. And we could, in other situations, not in this one so much, in other, and maybe even in this one, say, because of this increased market power, we estimate that there could be a price increase of X and Y and Z. Those are hypothetical, and there I would agree we should look into it further and see in fact what happens. But in the case of these estimates are based on a lot of previous activities. Do I have this right?
Yes, so on the physician side in particular, that is assuming that the physicians join existing contracts. And so those are already negotiated rates. And so it's really just adding more physicians to those and applying the same rates to them. As we noted, the parties didn't contest that there would be about $6 million in increases as the physicians join all of those existing partners' contracts. On the hospital side, we are looking at what Partners has done with its acute care hospitals in the past, and that's why we provide a range. Will they treat it more like their community hospitals? Will they treat it more like MGH? The Mass Eye and Ear physicians are part of Mass General Physicians Organization. It is a research and teaching institution that joins Mass General. It's very possible that they could treat it like MGH, and that's where you see that $60 million figure coming in. And so that's based on projections based on Partners' past practices.
I think to Dom's point, most of the major Partners acquisitions predated us, so we didn't have this type of analysis. I think where it's going to become particularly important is in the VI Leahy merger, where we have had a number of past consolidations with the VI, and as we present the analysis for that, I think it's incumbent upon us to go back and review what has been the experience with those transactions as a way of evaluating some of the possibilities for the future. And I know we've done some work on that, and the commission has seen some of that, but I suspect there's more that we would wish to see.
So I don't want to speak to the VIPness, but to the broader issue that Dr. Burke raises. He and I just may have a slightly different perspective. But the value of the Health Policy Commission as the commission matures. So let's assume, and I'm assuming, say this transaction goes through, and I'm not forecasting what will happen at the Public Health Council, what the recommendations of the DON staff will be. They take this information, they make it part of a whatever comes out of the DON process and the Public Health Council. Let's assume it were to be approved with a number of conditions, whatever those may be, that then provides a very public, several sets of very public documents of conditions. That, in my hope, and as David knows I keep saying, is that then it comes back to the cost trends hearing, and you have data where people have attested conditions that exist, and to hold the market accountable in a very public forum. Now, that is not necessarily, for some people's perspective, an additional regulatory authority. I would argue we don't need an additional regulatory authority, but that provides that information that continues to improve by demonstrating what people have stated, either in confidential documents or agreed to in public documents and conditions, and then hold them accountable to that. That they can either come back to the Health Policy Commission, either in like PITS or whatever, depending on what the issue is, or back to the Public Health Council, who does have the authority to place additional conditions or penalties. And I believe that that is how the legislature, I think, wanted this to work. I appreciate that comment. I'm just being a little sensitive to time from the last meeting we had, and I know we have another agenda item, but I don't want to stop this important conversation. And we won't have a forum, because I am out here.
So we will look into it. So with that said, the motion passes, and we haven't voted. We haven't voted. We need a vote.
We voted on the report. Yeah.
Let's vote on the report.
Yeah.
Yes. Okay. Okay. I'm losing it. Okay. Thank you, Pete. Good job. Okay.
So now we're going to move into the executive session, and we do need to take a vote to go into executive session. I'm just per our legal requirements, I've invited our general counsel up here to just highlight again why we're going into executive session and state for the public those reasons, and we'll take a vote and move in.
Just wait, do we have to formally vote to go, but to end this meeting, to end the public meeting, and then to go to general counsel?
Just the vote to go into executive session. That ends the public portion. So, as we have done previously, in order to comply with the statutory requirement governing the performance improvement plan process, which is that we keep confidential the identities of those entities identified to us by GIA is appropriate for the HPC, and as we've discussed in the past, to go into executive session to discuss the performance of those entities. And to continue that discussion today, it's appropriate to do so. As David mentioned earlier, we don't anticipate coming back to a public meeting after this session. And as always, the vote to go into executive session is by roll call.
So,
Any motion?
we need a motion and then we'll take a vote by roll call.
So moved.
Second.
All in favor? No, it's a roll call.
Okay.
Aye.
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 Great. Thank you, public, for attending this meeting, and we're gonna close and move into a closed session. And turn off the web streaming as well.
That'd be good.
Sorry, Wendy.
Was Wendy able to vote in the regular board meeting?
She has a